You're listening to The Q Switch with your host, Spence.
Welcome, one and all, to the Q Switch Conversations podcast. I'm your host, Spence, and the mission of this show is to tackle subjects currently impacting ophthalmology, where we invite the innovators, thought leaders, and forward thinkers shaping the field of ophthalmology to discuss their unique perspectives. So let's jump right in. Today's episode, titled Dr. Dolittle, Eat Your Heart Out, is for all you dog people out there. We've all looked at our dogs and caught ourselves wondering, if my dog could talk, what would it say? Well, if they were sitting in front of today's guest of the Q Switch, they wouldn't just be chatting her up about their day at the dog park or lobbying for treats. They'd be answering some very important questions during an eye exam. Joining me is Dr. Moriyon, a board-certified veterinarian, a veterinary ophthalmologist at Animal Eye Associates in Orlando, Florida. She trained at University of Florida, Ohio State, Long Island veterinary specialist, and completed her residency at Texas A&M before becoming a diplomat of the American College of Veterinary Ophthalmologists. She has a passion for intraocular surgery, corneal grafting, and ocular surface disease, and is deeply committed to improving not just vision, but quality of life for her four-legged and feathered patients and their families. Dr. Moriyon, as someone who truly enjoys animals and is a huge dog lover, this is such a treat to have you on today's episode of the Q Switch. Welcome to the show.
Yeah, I'm happy to be here.
Oh, great. Hey, so let's start at the beginning. What drew you into veterinary medicine and in the first place, and when did ophthalmology become that path for you?
Yeah, so a client asked me this the other day. She's like, how long did you know you wanted to be a veterinarian? And I actually have a picture of myself, I think like 10-ish years old, that my mom keeps. She actually put it in like my yearbook for my senior memories or whatever, where I made a little paragraph of it says, what do you want to be when you grow up? And I said, I want to be a veterinarian or an actress. And if I was a veterinarian, I want to work in the private practice setting. Here's where I'm at. That was foreshadowing by a 10-year-old. Now, ophthalmology specifically, I needed glasses in the 4th grade due to myopia, which is pretty common. And honestly, going to the eye doctor was one of my favorite doctors growing up. Like, I didn't find it scary. I found the whole premise of it pretty cool since I was very little. And just, I think having to navigate my own myopia and how it's progressed made me really interested in how the dynamics of the eye works in animals. And overall, my big thing with animals is like they show so much compassion to us as people. Like, they love us unconditionally. As their advocate, I want to be able to give back that compassion, right? Like, if they're compassionate towards us, I want to be able to mirror that for them the best way that I can, which is why I'm here. It's a pretty thorough synopsis of that journey or that thought process.
Well, thanks for sharing. So because this is a pretty specialized field, I think people would be surprised at what it takes to get there. Can you talk us through that journey from vet school to becoming a board-certified veterinary ophthalmologist and how that differs from a general veterinarian?
Overall standard for undergrad and vet school, you're looking at 8 years. It's very similar to medical school. So 4 years of undergrad, 4 years of professional school. For specialty medicine, this is ophthalmology or pretty much any specialty in veterinary medicine. We have to more commonly do a rotating internship or like a general internship. I guess it would compare to what physicians do, which is like a transitional year where it's general stuff. And then you don't automatically match like once you get into your rotating internship. You match step by step. So I finished vet school, you apply for or you're finishing vet school, you're in your senior year. You apply for the match, you get matched to a program, which is your rotating internship most of the time. And then in your rotating internship, you go through the match again. And so you either do a specialty internship, which veterinary ophthalmology is growing, but it's still a very small world. So the positions are few and far between. So let's say there's like 70 to 80 applicants a year, but only 12 residencies or 13 residencies.
Wow. That's super selective.
Correct. So then a lot of people end up having to do specialty internships, which is very common. I tell people who want to do ophthalmology that are in veterinary medicine, I explain to them, just expect to have to do a specialty internship nowadays, just because of how competitive it is. And so from your rotating, you go through the match again, you do the specialty internship most of the time. And then in your specialty internship, you go through the match again. So you go through the match two, 3 times, depending on how long it takes you to get in. to a residency. So ultimately, usually after the first specialty internship, you can match to a residency. But there's some people who do a couple specialty internships. So if you total out my journey, which I think is more or less the traditional journey for someone who didn't take like gap years and things like that, you're talking a total of 13 years of education from undergrad to finishing residency.
Wow. And you graduated from your residency about a year ago, right?
Yes, I finished. We're about to hit a year of me being off clinics.
Okay. So after all that training, you're now doing work that most people probably don't even realize exists. For someone hearing this for the first time, how would you describe what you do day to day as a veterinary ophthalmologist?
Yeah, so if you went to your ophthalmologist, minus the nice bells and whistles, our technology, just because of the overhead, is not as like we don't do OCT in private practice, right? OCT is reserved for that sort of imaging is reserved for academia, for research. And a lot of those research people are trying to get it more mainstream into private practice or clinically applicable if we can find uses for it and be efficient with it. But you're not going to see that here in private practice. What you're going to see is more of the slit lamp exam. So when you put your chin on that machine and they do the little light to go back and forth, we do those exams, but with a portable slit lamp. We do tonometry, typically with rebound tonometry. That's my preference, though we have used applanation tonometry, Schirmer tear tests, and fluorescein stain, and also a fundus exam. So using that indirect ophthalmoscopy to be able to look at the retina and the optic nerve. So that's pretty much the bread and butter of our exams. Anything that we do extra, meaning if we want to work up some more, we typically do diagnostic electroretinograms or ERGs. So that could be to see why a patient has lost vision if the eye exam is completely normal. Like if I don't see any changes to the retina, but I think there's a retinal issue, that might be the test that I go and reach for. But it's not standard every day, just for cases that need it. And then ocular ultrasounds is also fairly common to do. That's usually in preparation for cataract surgery. Or if we think that there's a retinal detachment, but there is a lot of opacity in the front of the eye that we can't see to the back, that's when we do it as well. So we do have, fun tools, but just not as advanced as what we might see in human medicine.
And I imagine there's a clear line between what you handle and what a general vet might see. What are the key differences between what a general veterinarian manages versus when a case comes through your doors at Animal Eye Associates?
Yeah, for us, it's going to be, it really comes down to the veterinarian's comfort level, right? Some things like early dry eye or a superficial corneal ulcer or even glaucoma, some general vets feel comfortable managing. Some don't. Some see glaucoma. If you're open to referral, please go to a veterinary ophthalmologist. And so it's more about the general practitioner's comfort level. Now, there's also parts like surgical stuff that would probably be better suited with an ophthalmologist, right? So cataract surgery, general practitioner is not going to do cataract surgery. They're probably not going to do glaucoma laser surgeries. They're not going to do corneal grafts just because they don't have the operating microscope, the micro tools, the microsurgery tools, as well as the fact that you see a veterinary ophthalmologist or human ophthalmologist do this, makes it look easy. But then when you go to do it yourself, especially when I started, I was like, wow, my hands are shaking. But if you look from afar, my hands are not shaking just because you're so zoomed in, right? So that is why I think the surgery part of things and the more advanced things like that tend to stay in the ophthalmology realm.
So now here's where it gets really interesting. Your patients can't tell you what's wrong. So how do you approach diagnosing eye conditions in animals?
Yeah, one thing, in physician med, I don't know the signalment or like the patterns of signalment that you might see. So what I mean by that is if we get a dog that comes in, a 6-year-old basset hound, and it's here for vision issues, I already have a semblance of an idea that glaucoma is going to be top on my list just from the signalment and the very brief history. So there are it's a pattern recognition component as well. But when we do our exam, maybe I go, oh, this is a basset hound. Maybe I'm struggling to do the Schirmers and I'm like, okay, I can't get a full minute, but I know it's not going to be dry eye because I don't see the clinical signs of dry eye. I don't see increased mucoid discharge. I don't see a lackluster cornea. So I might say, all right, let me focus my efforts on tonometry because the patient is losing his or her patience with me. So I go ahead and I do the tonometry and I confirm it that way.
So did you call it signalment? Is that what you called it?
Signalment. So yeah, that would be breed, age, sex, those sorts of things.
So I know that there are certain breeds that are predisposed to certain conditions like dachshunds because they have the longer torso or the longer bodies that they have lots of vertebrae or back or spinal issues. Some have like gastrointestinal issues that I know, like what's when the stomach flips. I forgot what they call it.
GDV or gastrodilation volvulus. Yep.
Yeah. So I had an Akita growing up, and they're predisposed to that or risk of that. Yeah. So you're saying that this signalment, there's certain breeds that come in with a history of these conditions, then you can rule other stuff out.
Right. From just the signalment. Now you do your exam and sometimes you get surprised. Walking in, the signalment can tell you a lot. There are some breeds like Boston Terriers and Shih Tzus, hit or miss on the Bulldogs. They fall into so many categories. It's a surprise, and the history might kind of guide you a little bit further.
So because obviously they can't talk to you, there are ways they can communicate, or there are signs and signals that you can read and understand what path to take in terms of diagnosing the patient, sounds like.
Yeah, it's mostly the clinical signs, and some like squinting is pretty nonspecific because squinting can mean dry eye, squinting can mean an ulcer, squinting can mean glaucoma. But if you tell me squinting, cloudiness, increased redness, and possible visual deficits, I'm starting to lean glaucoma, right? If you tell me squinting, redness, increased discharge, I might start to think that I'm going to look for dry eye. But also an ulcer might fit into that. So there are things that they show us on their exam that help a lot. And in regards to pain, even hearing like these visual deficits started and then my pet got lethargic and doesn't really want to eat. And then you look at the exam and you find the dog has glaucoma because, a pressure of around 40, we tell people that's probably when they start feeling a migraine-like pain. And the eye is so closely associated with jaw that they may not want to eat. They just don't feel very well. And I'll go touch that patient on the head on the side that the pressure's high, and it's a head shy movement of please don't touch that side of my face because it hurts. So there are things that we can behaviorally that we start seeing on our patients that are very minor that might potentially lead us one way or the other.
So once you've figured out what's going on, I'm curious what you see most often. What are the most common eye diseases you see in animals, and how do they typically present?
Yeah, so most common would be dry eye is very common. Both the quantity, so like the actual Schirmer tear test being low, or the quality of the tear film, so just either the fatty part, the oily part, or the watery parts, mostly the fatty or the mucousy part that tends to be a problem if you're talking quality. So dry eye, glaucoma is very, very common. Cataracts are pretty common, both of the hereditary kind, congenital kind, and diabetic kind, particularly in dogs, the diabetic kind. The ulcers are pretty common, and most of the time we get them when they're infected ulcers or when we get something called a spontaneous chronic corneal epithelial defect or a SCED. I like to call it an indolent ulcer just because to me it's much easier.
Kudos to you.
Yeah, to me, it's a lot easier to say indolent ulcer, but it's also called a SCED. And for those, it's kind of like recurrent corneal erosions in people, right? So it's got a different name, but there's similarities. So we might see those type of ulcers as well because they require debridements, like diamond burr debridements. And some vets may have either already tried to debride it or just don't feel comfortable, don't have the tool. So you might see those as well.
And from there, you're making decisions that can range from simple to highly complex. How do you determine when something can be managed medically versus when surgery becomes necessary?
Yes. So that is going to depend. Let's talk about an ulcer, for example, the surface area of the ulcer itself. So if the surface area is 80% of the eye, and most of the time when we repair these, we're doing conjunctival pedicle grafts or corneal conjunctival transpositions. We are trying to graft an area that's small because we don't want to affect the patient's visual access. So ultimately, if it's very large and if affecting a large part of the corneal surface area, we might say, hey, there's light perception and there's a chance to potentially preserve vision, but the graft itself may be functionally blinding because we're going to put this opaque tissue over the clear surface, right? So that may affect candidacy for that sort of patient. The fact dazzle to me is so important. The light perceptions, the light reflexes are so important because it tells us a lot about the retina. And so a dog that may have a dazzle, so again, infected ulcer, a lot of melting, may need a corneal graft or repair. If they have a dazzle, which is basically I shine a bright light in the eye and they go, oh, I see that, or I feel that.
It's a dazzle. It's called a dazzle.
Yeah, it's a dazzle.
Okay.
Then we say, okay, this might have a chance for vision preservation, so we should try to do a graft. Versus if they don't have a dazzle, And the other thing you can check for is a consensual PLR to the other eye. So shine a bright light into this pupil. Does this pupil constrict? That's normal. So if it's not constricting, we know light perception is an issue as well. Then we might say, hey, unfortunately, your patient or your pet lacks light perception. So I don't think that a corneal graft would be beneficial because the goal of the graft is to, like I said, preserve vision and keep the globe or the eye itself comfortable. If we lose vision and we think that the prognosis for vision is very guarded, meaning very unlikely to save it, maybe we should consider either aggressively medically treating so that we can save the eye itself, or consider eye removal just because this might take several weeks to heal. It's a very fragile eye, could lead to affections of the tissues around the eye if it consistently perforates because it's so fragile.
Mm-hmm.
So that's how we determine that light perception's a biggie. And then some things like ulcers, it's surface area. But light perception translates to glaucoma. Is there still some sort of a weak dazzle and we're on maximum medication? So do we try the Hail Mary surgical approach of a laser and or a shunt? It's just kind of preference in veterinary medicine. And then cataract surgery, since it's more elective, not urgent, we tend to asked to do a ERG to check electrical function of the retina to make sure it works, and then a sonogram or an ocular ultrasound to make sure that that retina is attached, because sometimes you'll have a dazzle and a PLR, so you'll have light perception, but the retina is detached behind the cataract because you can't see. And then we find out that information, and having that information is helpful because it might take away candidacy for that patient to have cataract surgery to say, hey, the retina is attached. If we take the cataract out, we're not going to improve vision. And that's to say some of those patients we send to, there's a handful of vitreoretinal veterinary ophthalmologists.
Wow. Beyond being a veterinary ophthalmologist, they are a retina specialist, a vitreoretinal specialist on top of that.
Right. So there's
That's
no
crazy.
true fellowship or subspecialty specifically, but it's people who went and sought out extra training for retinal reattachment surgery. So some of those cases that are working up for cataracts and we find a retinal detachment, sometimes we send them to one of those specialists, even though it's going to be probably hours away drive, depending on where you're located, if they're very motivated to have the cataract surgery done and the retina reattached at the same time. And so my time at Long Island Veterinary Specialist, my main mentor, I had two, was a vitreoretinal surgeon. So I did see and got to participate in quite a bit of vitreoretinal cases. And it was a really cool surgery to see. It's very involved. It requires a lot of supplies. But we did do, bilateral cataract surgery with a retina reattachment in one eye, and things like that. Cases like that would come to that practice in Long Island, New York.
So you just mentioned some of the more routine surgeries that you specialize in. Are there any unique surgeries that you don't see very often that you're like really excited and like look forward to seeing when they do show up?
Yeah, I think your retinal reattachment is probably the most specialized, but still somewhat common-ish surgery that would fall into that category, because not everyone gets to see them or participate in them. There are, people who are more attuned to eyelid blepharoplasties and stuff like that, those sorts of surgeries. There are multiple ways to fix an eyelid. And some people get really fancy with it, or like depending on the size of the mass, the location of the mass, if there's an eyelid mass, or the lesion, whatever lesion it may be. There are people who get very excited about, I want to try this approach. I want to change this, or, and they modify things. So if you ever look at the veterinary ophthalmology textbook eyelid chapter, it's just a lot of different ways to fix different things. And so for me, I will do eyelid surgery, but it's not a passion of mine the way that microsurgery or intraocular surgery is. So I will experiment with those, but not as much as I like to get into the intraocular, microsurgery realm.
I have to imagine this is very different from human ophthalmology. What are the biggest differences or challenges when performing eye surgery on animals compared to humans?
Well, they need general anesthesia. So in humans, they use a paralytic and you're mostly awake, I feel like, for a fair amount of these surgeries. In dogs and cats, they have to be anesthetized and they have a paralytic on top of that. So the paralytic mostly helps the eye positioning because anesthesia will have you roll your eyes inward and downward. And so that muscle relaxation with the paralytic will bring it back center. And we place stay sutures to help us manipulate the eye as well as using our forceps. But I think that's the main difference in overall all microsurgery is that we need general anesthesia for these procedures for our pets. The other nuances would be like specific to cataract surgery. Our eyes are very, like human eyes are very forgiving for inflammation in comparison to dog eyes, for example. Dog eyes are a little bit more sensitive to intraocular inflammation, which we induce when we go in to cut into the eye. And then if you compare even between species, a cat's eye, we always say cats are like aliens. Cats, like they have barely any inflammation after cataract surgery, which is fairly rare to do a cataract surgery on a cat, I will say. And then their corneas also heal very magically. Like if you do a corneal graft or a keratectomy, they heal beautifully no matter how that surgery went.
So, and to do all this, you must rely on some pretty unique tools and advanced instruments. What kind of technology and equipment are essential in your practice, and how has that evolved?
So operating microscope, I feel like that's like bread and butter for any sort of microsurgery.
Mm-hmm.
The actual phaco machines are very similar to human medicine. And for example, we use an Alcon Centurion here. Some other practices I've been on use a Bausch& Lomb Stellaris. Then there's more obscure machines that I hadn't seen before, like a White Star was what I had in my residency.
Oh, Johnson & Johnson.
But we do, yeah, exactly. So we do have a fair amount of access to the peristaltic pumps, to the Venturi pumps. So like that sort of stuff is very similar. Like I've gone into the Alcon facility and they show us this like VR situation or like 3D sort of thing that they're starting to, incorporate. We don't have that. We're not that fancy just yet. So we're still just on the phaco machines. Other sorts of tools, we have an Iridex, so specific like diode laser. We don't tend to do the ND YAG laser that they have in human medicine. Just diode is more commonly what we see, other than your diagnostic machines, which we talked about, the ERG and the ocular ultrasound. That's basically it in regards to the stuff you need most commonly. That's the bulk of it.
It's surprisingly, use a lot of the same equipment that I see as I'm in and out of ORs for humans. I mean, you talk about Centurion, White Star, and some of these other, those are all the same manufacturers, same equipment, just using it on animals, which I shouldn't be surprised, but I totally am. So let's now shift to the experience side of things. How do you assess pain, healing, and success when your patients can't communicate how they feel? What are some of the key things you look at to, again, assess pain, healing, and success?
Yeah, so the main manifestation of pain in dogs, when you're talking ophthalmology, is going to be squinting. But I feel like that's typically more acute pain because your acute glaucoma dog is going to be squinting, but your chronic glaucoma dog is not going to be squinting. So that's not to say that the chronic glaucoma dog isn't uncomfortable, but that acute pain, he's gotten either accustomed to it or felt like a lingering migraine at that point. We're talking chronic glaucoma, which is harder to evaluate because their eyes are usually wide open. So squinting is number one. And we do use it to trend comfort or like improvement. So if there's an improvement in squinting, most of the time there's an improvement in comfort. And an ulcer is the best way to look at that. The nerves are all located on the interior part of the cornea. Then there's a chunk where there's not really any nerve endings. So there is this nuance that sometimes comfort might mean that it's deeper until it gets all the way to the inner lining of the cornea. But most of the time, when we're talking about an ulcer, improved comfort usually means it's epithelializing. So that top layer of the cornea, the epithelium is coming in, sealing everything down. The reflex uveitis, for us, we get like photophobic. I've had that feeling before. I've had an ulcer where I stare into the light and I'm like, ow. That improves as the reflex uveitis improves. And sometimes we can control that with the use of atropine because it controls the ciliary spasms. And so that's sometimes why we include that in our ulcer protocol. But that's the main thing we look at for comfort. The other thing we look at is overall behavior at home. So as I said before, sometimes owners will be like, my pet is lethargic. My pet is not wanting to eat. And then we start treating, the eye problem. And all of a sudden they're like, he's back to being his old self. And that's glaucoma, like to me, is the main staple for that sort of behavioral change. This like lethargy, feeling unwell. I always tell people, think like if you had a migraine. When you get up, you don't want to do anything. And that's kind of how your dog probably feels. And so when we tend to fix that, whether with medications or with surgery, they'll be like, wow, they're back to normal. And that's how I also preface when we talk about eye removal, because enucleation, it's not something easy to accept, and I can completely understand that. because we don't ever want to change the appearance of our pets, just like we don't want to change our appearance, right? The big thing there is I've had conversations with owners and I'm like, I think you would be pleasantly surprised because your dog's pressure is 50 on maximum glaucoma medication with very poor prognosis for vision, like basically near zero. I always tell people I can't say zero, but near zero. You would be surprised how much better we can make him or her feel if we remove the eye. And we submit the eye for biopsy, which will let us have information on the good eye to let us know if we need to worry about the good eye. So they'll be like really reluctant. And, 2 weeks later when they come for the post-op, they're like, oh my God, my dog is back to normal. Oh, he's chasing lizards. He's doing this. He's doing that. And I'm like, I tell you, sometimes our pets don't outwardly show us that they're really uncomfortable. And it might be very subtle things, but then you see a difference.
So for humans, ophthalmologists look for like visual acuity, how good can we get their vision, 2020, 2015, whatever it is. Are you looking for visual acuity in animal outcomes or more so comfort? And what are some of the objectives in terms of the outcomes that you look to achieve?
For dogs and cats, it's more cut and dry. Is there vision? Is there not vision?
Okay.
On regular private practice, regular clinical ophthalmology, we're unable to assess because they can't speak their actual visual acuity. And when we change the lenses, we're not able to do
one
that.
or two. Mm-hmm.
Yeah, exactly. We tend to just measure vision crudely. So what's called a menace response. It's basically you cover one eye and you come at them like this with your hand, try not to blow wind in their face and see if they flinch. And we do that for both eyes. And that gives us a crude evaluation of if, yes, they can see, no, they can't see. Now we have owners come in and they go, hey, he sees his tree, but he goes to the left. Like the depth perception seems off, typically in our older patients. And that's very hard for me to tell them, yeah, he has a +3 prescription. I can't do that. So I would have to explain, okay, I see nuclear sclerosis. For us, when we have nuclear sclerosis, it just gets treated like a cataract because you or I need to read the newspaper. We need to drive. We need to do things that require visual acuity. A dog doesn't have to do those sorts of things day to day. So yes, the depth perception may be altered by the nuclear sclerosis, but cut and dry, your dog's vision is still there. In veterinary ophthalmology, some people say, like, should we do cataracts on these patients or not? And I think our success rate for cataract surgery is not as good, like I said before, as in human medicine. So we run the risk of potentially blinding complications just to fix some depth perception. So I think until we get the results, which we're still pretty good, success rate for cataract surgery, somewhere 85 to 90% within 1 to 2 years after surgery. Yeah, so it's still pretty good. But still, when you succumb and you fall into that 10 to 15%, and it was just a nuclear sclerosis case, I've seen owners beat themselves up over that sort of situation because they were like, let's do it. I understand the risks. I want to do it. And then they end up on the other end having those complications. And then they're like, man, maybe I shouldn't have done it. I usually tell people nuclear sclerosis, most of the time I just leave alone. Yes, he may be missing the tree a little bit, but he can still see cut and dry versus, a true blinding mature cataract where I'm like, yeah, he's bumping into walls. Like that one we should probably consider doing. It's still elective, but consider doing surgery.
So you've mentioned dogs and cats throughout our discussion, but your practice, and I'm not sure if you do other animals other than just dogs and cats, like large animal, like farm animals, birds. I mean, what other animals do you work on for ophthalmology?
Yeah. So we're one of the veterinary specialties that can work on any species of animal. So dogs and cats are the bread and butter. It's what most people do. Horses probably would be the third common species. And then the exotics opens up anything, right? Lizards, frogs, birds of any sort. I've seen a white rhino, zebra.
You yourself?
Yeah. By training, I've been able to examine the eyes on these patients. And there are people who focus on aquatics. So there's a lot of people who do sea lions and even fish. Like fish we can examine. If it has an eyeball, we can look at it.
And you're saying that your practice is one of the few that can do all animals?
Our specialty overall. So the college, College of Veterinary Ophthalmology, of our the whole specialty versus some specialties in veterinary medicine are specifically like small animal internal medicine or large animal internal medicine.
Okay.
Ophthalmology is just anything with an eye. And our practice here at Animal Eye Associates, we we do exotics. We don't tend to do equine because we have to go out into the field for that.
Right.
We do see, like I saw a duck. It's on our social media page. I saw a duck. It got attacked by a hawk. We've seen a pigeon recently. We see actual hawks as well. So like we've seen exotic
What?
pets a lot.
So I've been around tons of human eyes, just nature of what I do. But also when I do wet labs, different teaching programs, they would use pig eyes for wet labs. And those things are huge. I mean, the different range of size and like anterior versus posterior chambers on the different eyes, do you have to account for some of those differences between, say, a cow eye versus a dog eye?
Yes. And I think the cat example is a great example, going back to cataract surgery. The anterior chamber in a dog and the anterior chamber in a cat, very different in size. Though I haven't had the privilege yet to do a cataract surgery, I've been able to assist in my training in these surgeries. And I remember one of my mentors, we do dogs most of the time for cataract surgeries. She was in there doing her surgery and she was like, wow, this anterior chamber I feel very deep into this anterior chamber right now. So there is differences. Pupil shape is different, right? So like if you've ever seen pictures of certain reptiles, they have different pupil shape. You might see like in horses, it's more ovoid, horizontal oriented, and they have like a corpora nigra, which is this like structure that people argue provides some shade to like the pupil and the retina. So there are different structures too between species. Like birds have bony ossicles. Birds are interesting. They have skeletal muscles on their iris so they can control their PLRs. So you have to be careful. You can't really interpret a PLR in a bird because they can control the constriction of their pupil.
What?
Their actual septum in between the eyes is very thin. So if I shine a bright light in this eye, because it's so thin, it's going to shine into this side too. So that's also why you can't look at the PLRs and some, avian species.
Wow.
There's a whole recently released 2-volume textbook of wildlife ophthalmology where it talks about all these differences.
That is, wow, mind blown. I never would have thought. And of course, there's another very important part of the equation. What role do pet owners play in the treatment process, and how do you guide them through what can be emotional decisions?
Yes, the client, the owner, is the primary advocate. Right. And my main thing when I talk to them is you and I are on the same team, but you know your pet better than I know your pet. You're always going to know your pet better than I know your pet. All I'm here to do is try to help you be able to help your pet. And so we have conversations and some of them are tough. So like, again, the eye removal conversation is very tough conversation, or acute vision loss due to what we call sudden acquired retinal degeneration syndrome is very difficult conversation because the eye itself for that diagnosis is very healthy looking, but the retinal function is gone. It's distinguished, it's flat. And so the patient doesn't have vision as a result. And, based off the majority consensus, there is no treatment for that diagnosis, no consistent treatment for that diagnosis. And so it's hard to relay that to the owners to say, hey, we don't have a consistent treatment protocol for this. Sometimes we do explore empiric therapy with use of oral steroids and maybe an oral antibiotic like doxycycline, because there's this nebulous, like, is there this immune-mediated retinitis thing going on? But those are tough conversations to have. And sometimes we frame them in ways where we're like, I understand that your pet is blind. Ultimately, we ruled out that the vision loss is neurologic, right? So we ruled out that the vision loss is due to a brain tumor or something that's neurologic in the brain itself that's affecting the visual cortex, because that would require you then to go to the veterinary neurologist, to go then get an MRI, to then go treat whatever this is that may affect the rest of the body and the rest of the brain. So it's all about understanding and empathizing. Like I have pets and we all have pets. We all want to do the best for our pets, right? So it's all about understanding and empathizing, but also providing them realistic expectations and trying to make your pet comfortable, which is the goal at this point.
So I think that's a great segue into my next question that's, I think, really important for our audience. At what point should someone seek out a veterinary ophthalmologist instead of relying on their primary vet?
That is a great question. I think that also depends on level of comfort of your general vet, right? I know that there are people who've been with their general vet for 30, 40 years, like multiple generations of pets that they may have owned. And I still think that the general practitioner is the front line, the informative person. Um, Now, it's nice to have that general practitioner because sometimes too the cost of specialty medicine is not feasible for some people. So the general vet can and triage some of these things and provide comfort, right? So eye removal, nucleation can be done with a general vet. And I've had clients come here, get evaluated. I tell them, hey, unfortunately, I think eye removal is the best option. And I'll be quite honest with them. I'll say, I'm happy to do it. This is the cost here. It's this cost because it's done at a specialty facility. But if you go to your general vet and they feel comfortable doing the procedure, because some of them don't, then you can go to your vet and see if they can do the procedure. And then I just emphasize at that point, please, please, please submit the eye for biopsy because it can give you so much information for the other eye, now that your pet only is going to have one eye, right? That line is blurred. Veterinary ophthalmology, most places you don't need a referral, meaning if you see your dog, it has an eye issue and you want to jump to the specialist to begin with, you can do that. You don't have to see the general practitioner. You can always jump and go directly to the specialist. It's really owner preference, also owner financial, capabilities. Or are they able to pay the specialist fee? Or, general practitioner comfort is also that. Because sometimes general practitioners, they'll come to their general vet. The vet will look at it, see that it's very not okay, and be like, hey, why don't you turn around and go to the specialist because this is going to require a bit of work. So I think the cases are hit or miss of where it's going to go. But ultimately, it's like I said earlier, if it needs some sort of specialized surgery, like a microsurgery, the vet most of the time will send it over immediately. Or if the person has experienced it before, so it's an owner that's had like 25 pugs throughout their life, they're going to be like, I know that I got to go to the ophthalmologist because I know this is probably going to need some help.
Right. So your colleagues, Dr. Priest and Dr. Dennis, have practiced veterinary ophthalmology for 40 and 30 years respectively. How has veterinary ophthalmology evolved from their generation to yours, and where do you see it going?
Yes, Dr. Priest and Dr. Dennis did their residency at a time where you didn't have to do a specialty internship. The ophthalmology college was relatively new. It was relatively a baby around that time. And I say relatively because if Dr. Priest hears this, he's going to be like, oh my gosh, you're aging me. But ultimately, it was it was a relatively new specialty, right? And back then, we do model a lot of what we do based off what is done in physician ophthalmology, right? There was PMMA lenses. So they used to have to make really big corneal incisions to place an artificial lens. And then eventually we developed these acrylic foldable lenses in physician medicine. And so we said, let's adopt that in veterinary ophthalmology. So they've been able to see that progression of like the things that were done way back when to now. And there's a constant churn of new information in veterinary ophthalmology. We actually have a journal called Veterinary Ophthalmology. If anybody ever wants to do a search, you can look at all the things that people publish. The research, though, in veterinary medicine in general, the sample sizes are obviously a lot smaller. The amount of articles released about certain subjects are a lot less frequent than in physician literature because physician literature, the numbers are massive. The information we have is always going to be based off a smaller sample size, and we're not going to have as much meta-analyses or like basically consolidation of all these studies to provide a huge consensus. So that's why there's still some hot topics like sudden acquired retinal degeneration syndrome, which we see in dogs, that there's different camps that follow different perspectives of like, they think it's an endocrine related issue. They think it's an immune mediated related issue. They think it's a cancer associated issue. But ultimately, we don't have enough concrete or like meta-analyses information to say, yep, this is what it is. We feel confident about it. So, and over the years, Dr. Priest and Dr. Dennis have seen that development, right? So it was once reported, and then from there, all these theories have come out. And so they've had to adjust how they practice based off these new developments. But overall, the training-wise part of it, there was no need for specialty internships back then. So they had a little bit of a shorter route to get here in that regard, but otherwise, not. And then the reliance on Google and PubMed and all those things, the amount of information we can get in a moment's notice from the internet. You see it in the way that, I had to train for residency versus maybe some of the older generation had to train. They relied a lot on books and a lot on physical paper printed editions of veterinary ophthalmology to sit and study for boards. So the amount of journals they had to read, even though they had to read still a good amount of journals, was probably a lot less than what we have to read now to sit for boards, which I think is over like 1,000 journal articles. If you can look up the reading list, there's a public document, but there's a bunch of textbooks from even like the 80s to now that we could get asked questions on. So I think that amount of information has gotten so vast for the newer generation of ophthalmologists compared to what it used to be when they had to sit for boards.
So human ophthalmology, there's a shortfall of the amount of ophthalmologists to meet the future demand of patients clinically and surgically. In your area, veterinary ophthalmology, is it similar, or is the specialty growing? Is there a demand for more folks like yourselves in the veterinary space?
Yes. So there is definitely a demand for more veterinary ophthalmologists. I think the college is trying to keep up with it. So I think over time we're opening more residency positions, which therefore will lead to more ophthalmologists. But I think the supply is still very low compared to the demand. And I think a part of that is just overall how the pet industry has grown, right? So like we're doing way more for our pets nowadays, and they're living a lot longer than they were years ago. So to keep up with that demand, we have to bring out more ophthalmologists. I don't know, right now the residencies are trying to keep up. But I don't know that I think it's still going to be a bit short for a while.
For someone listening who might be inspired by your journey, what would you say to someone considering this path? Why should they pursue it? And what's the best advice you could give them?
So for me, if you're talking veterinary medicine in general, you have to be prepared to deal with a very struggle in income debt ratio. And if you're talking veterinary medicine in general, because our school debt does end up being more than what we would generate maybe as a general practitioner. So it's definitely something you have to love. It's definitely something you have to be passionate about. And it's definitely something you have to be okay potentially living a bit tight for, X amount of time or whatever your strategy or plan is. Now for residency, specifically in ophthalmology, a couple things. It's competitive enough that I do think that there should be some motivation to keep your grades up through vet school. Some people, vet school's hard. I don't deny that. And we get into this comfort of, C's get degrees, and we should strive to pass. That's the goal, to pass, to be a doctor, because at the end of the day, whether you're the last in the class or the top of the class, you're still a veterinarian, right? But I think for trying to get into a competitive specialty, it does matter how involved you are, your grades with your involvement. If you get into research, networking is so important. So I went to the veterinary ophthalmology conference as a second-year vet student when I made the decision definitively this is the route I want to go. And even though I felt very out of place and like a baby, because everybody was like, when you're striving to be somebody and you meet them and you're like, oh my gosh, I want to be you. Right. Even though you felt uncomfortable, you start building relationships and you start learning more about the path and getting information on how to get there. And that's all very helpful for that scenario. And so I say that because I've been on panels of students, like with students as a resident. They, other specialties will be like, kick back, it's chill, you don't have to make a decision. And I don't know, I think ophthalmology, because it's so small and you have to have a plan of like setting yourself up well in school. I'm not saying you have to make a decision the day you walk in the door, but maybe as you start ending your vet school, have an idea and make sure that you kept yourself up in the beginning when you're trying to make a decision.
And so before we wrap up, I have to ask, after working with other people's animals all day, what pets do you come home to as a part of your family, and what are they like?
Yeah, so I have 2 Australian Shepherds, a German Shepherd, and 2 cats.
Wow, it's a lot of animals.
A lot. Yep, a lot. I never thought I would reach my limit, but right now I'm like, whoa, okay, too much. But I love them to death. My dogs, I use them as a great example. We talk about a lot of patients come in, they're very anxious and they're like vibrating or they're jumping off walls, or every dog has a different personality. And for us, with the slit lamp, we're very magnified. And so sometimes I explain to owners, hey, I think your dog needs to come in on some oral sedatives. Don't need them knocked out, but I need them cool and collected. So I use my dogs as an example to say, hey, I have Australian Shepherds at home. I know what jumping off walls is like, okay? But I really think we need to do maybe a little bit of gabapentin, a little bit of trazodone. Not all the time. I'm not saying you have to sedate them all the time, just so that I can get a good eye exam, because you're asking me why your dog is squinting and I'm trying to get a magnified look for distichia or some sort of hair that's poking on your dog's eye. But this movement is not really helping me stay still. That's arguably the hardest part of my job, is the movement like this. I joke around when I was a resident with the students. I would say, I'm going to go to my ophthalmologist and do this and see how they feel about it because they're not going to like it. So for me, that I do use my own pets and my experience with them to be able to reason or empathize with my clients.
Well, it's never a dull moment in your house, that's for sure. With what was it, 4 dogs and 2 cats, or 4 dogs, 3 cats?
3 dogs and 2 cats, but the German Shepherd is basically the size of 2 Australians, so you could say 4.
So before we let you go, Dr. Moriyon, for anyone listening, whether they're curious about the profession or live in Central Florida and may need your expertise, what is the best way for them to connect with you or learn more about Animal Eye Associates? And I think you mentioned earlier you have an Instagram page as well. Why don't you go and share that too?
Yeah, so our Instagram account, it's at Animal Eye ASOC. So if you ever want to take a look, we do post a lot of educational videos. Sometimes we make fun of ourselves. We do quite enjoy making fun of ourselves. And then if you ever have more fine-tuned shadowing opportunity questions or anything like that, our email is animaleyegroup@gmail.com. That's the best way to contact us for any sort of, more business, formal related questions. But otherwise, our Instagram is a really great tool. And it has links there to be able to jump onto our Facebook and to our TikTok. But I think the Instagram is going to be our main staple on that one.
So everyone out there, give that a follow. So Dr. Moriyon, this has been such a fascinating conversation. You've given us a window into a world that most people never think about, but one that requires an incredible level of skill, precision, and compassion. What really stands out is not just the technical expertise, but the impact you're making, restoring vision, relieving pain, and strengthening the bond between pets and the people who love them. So thank you for your work and what you do, and thank you for sharing your story and your insights with us today. I really do appreciate it.
Yeah, thank you for having me. It's been fun.
Well, great. Hey, so as always, to my audience, the Q-Switch Conversations podcast is my way of giving back to an eye care industry and community that's shaped my career, my perspective, and my passion for what we do. This platform is truly built for you, the clinicians, the innovators, and change makers redefining what's possible in our field. So if you have got a fresh perspective, a unique experience, or know someone doing great things in eye care, I'd love to feature them on the show. You can hit me up on LinkedIn or drop me a line at d.spence. And as always, we'd like to thank Riverside.fm and Passionate Media for making this show happen, and of course, our benefactors in Meridian Medical for making it all possible. That's a wrap for this episode of the Q-Switch Conversations podcast. Until next time, this is Spence, and I'm out.
You're listening to The Q-Switch with your host, Spence.